there, my name is Eleni Jaswa, and I am an assistant professor of reproductive endocrinology and infertility at UCSF Center for Reproductive Health. And today I'm going to be talking a little bit about recurrent pregnancy loss, or RPL. To begin by letting you know what we'll be discussing today, we'll begin with the epidemiology of the disease, who it affects, the diagnosis of recurrent pregnancy loss and workup accordingly, what treatment options are currently available in 2025 for couples affected by recurrent pregnancy loss, and lastly, I'll give you a bit of information about future research directions and things that I'm excited about for the field. By way of introduction, miscarriage is common. It's estimated that up to perhaps a third of conceptions result in clinically recognized miscarriage, and it's felt to be nature's way of sorting out pregnancies that were never going to be healthy babies. On the other hand, recurrent pregnancy loss, or two or more miscarriages, is less common, and it's estimated to affect about 2% of reproductive age women. Causes of recurrent pregnancy loss include four basic categories that are known to date. One causes genetic issues, another anatomic issues, generally with the uterus. A third is hormonal issues, and fourth is immunological or autoimmune factors. Despite the litany of tests available and recommended for recurrent pregnancy loss, frustratingly, about 50% of our couples with RPL will have a diagnosis of unexplained RPL, which just means we were unable to find anything wrong. Focusing in a little bit more on each category, when we think about genetic causes of recurrent pregnancy loss, we tend to think of issues at the chromosomal level, perhaps a balanced translocation where genetic material is exchanged between chromosomes. When we think about anatomic issues, generally we're thinking about congenital issues with uterus formation, for example, septum, or other issues such as fibroids, which can be acquired during the course of a woman's life. Hormonal issues such as thyroid dysfunction or undiagnosed diabetes may play a role in miscarriage as well. Antiphospholipid antibody syndrome is an immunological syndrome in which women acquire antibodies which can attack the placenta of a growing pregnancy, predisposing to miscarriage. Lastly, we will discuss lifestyle considerations for couples with miscarriage issues. The diagnostic approach parallels much of medicine. We begin with a detailed history and physical examination. We'll often include laboratory tests such as blood tests, and finally, imaging is a common part of the workup of the couple affected by RPL. Lab testing gets at those categories we previously discussed, including testing of TSH, thyroid stimulating hormone, hemoglobin A1C to get an assessment of the average blood glucose over the past 3 months. Genetic testing involves karyotypes to look at the chromosomal arrangement of DNA in both partners. We test the female partner for 5 different antiphospholipid antibodies. Some practitioners will check coagulation profiles with the thought process that blood clotting may predispose to miscarriage. This is typically advised only in the setting of a personal or family history of recurrent clotting issues. Imaging studies are intended to take a look at the inside of the uterine cavity, and we typically at UCSF will use a modality called saline-infused ultrasonography, in which the uterus, which is typically a collapsed potential space, is opened up by instilling saline, think of it like blowing up a balloon, to really interrogate the contour on the inside of the uterus and examine for problems like septum, fibroids, or polyps impinging on the cavity. The thought process is that An embryo, if implanted in an abnormal tissue inside the uterus, may fail to take root appropriately in the placentation problem and may be predisposed to miscarry. Other modalities for anatomical examination include MRI, as well as hysteroscopy, in which we can look directly inside the uterus ourselves using a hysteroscope. Treatment of couples with recurrent pregnancy loss focuses first on treating any underlying causes identified in that 50% of couples in which an issue will be found. So, for example, in the setting of antiphospholipid antibody syndrome, pharmacologic treatment with anticoagulants or blood thinners is first line. If an anatomic issue is identified, a surgical correction, generally with a hysteroscopic approach, is recommended. Other couples consider IVF with genetic testing, PGTA, which stands for pre-implantation genetic testing for aneuploidy, to reduce recurrent risk of aneuploid-related miscarriage. So if a couple, for example, has tests of pregnancy tissue from miscarriage specimens that repeatedly showed an extra or missing chromosome, which was the source of the miscarriage, genetic testing may sort out those affected embryos prior to them having a chance to implant in the uterus. Lastly, lifestyle considerations such as smoking cessation and maintaining a healthy weight are reviewed with all RPL couples. The medications given for couples with recurrent pregnancy loss include, as we discussed, blood thinners for antiphospholipid antibody syndrome. If there is an issue with glucose control, like prediabetes or diabetes, or thyroid dysfunction, medications are used accordingly. There is a robust literature on progesterone supplementation, which has overall been disappointing as a measure for reducing RPL. However, there are some specific scenarios in which progesterone supplementation may be warranted, and I suggest talking to your doctor about whether or not this applies to you. The image on the left is a view of a hysteroscopy, so inside the uterus. You can see a bridging band of tissue in the midline, which is a uterine septum, a fibrous band that women are born with, related to how the uterus develops from two tubes initially. A hysteroscopic resection of this includes passing a small camera through the cervix into the uterus and using tiny instruments to open up that fibrous band. Sometimes laparoscopy is warranted for complex surgical cases. To genetically test embryos prior to implantation, IVF is required. During the IVF process, a woman can anticipate approximately 2 weeks of ovarian stimulation, giving herself 2 to 3 shots a day, and coming into her doctor for frequent monitoring appointments with ultrasound and blood test. A procedure to remove those eggs from the body under anesthesia. And then the eggs can be combined with sperm to generate embryos, which can be biopsied at the blastocyst stage around day 5 or 6 of life. And a couple weeks later, the complex bioinformatics can return from next generation sequencing to yield a diagnosis of the euploidy or aneuploidy of those embryos, and screen out embryos that do not have a chance at becoming a healthy baby. There are data suggesting that IVF with genetic testing can reduce miscarriage risk, especially among older women, but not all studies consistently show it accelerates time to live birth for all RPL couples, which is an important consideration. Evidence-based lifestyle factors contributing to recurrent pregnancy loss include tobacco, so smoking should be stopped. Alcohol has been linked with issues, and so limiting alcohol to moderation or less is warranted. And lastly, having a healthy weight or BMI is important, although no specific diet or exercise regimen has been linked to miscarriage risk per se. Lastly, I think it's really important to acknowledge that any miscarriage, certainly repeated miscarriages takes a psychological toll on those who suffer. It's a traumatic experience, and each subsequent pregnancy can become progressively challenging as a woman recalls the prior failed pregnancy or miscarriage, which can be quite traumatizing. And so, treating a person as a whole human with adequate referrals and psychological support to address the anxiety and depression that have been associated with it are really, really crucial in caring for these patients. I will mention a study that showed that TLC, tender loving care of couples with RPL, which might include extra ultrasounds early on, especially around the time of the prior loss, can really help support the couple in their experience and outcome. As I mentioned, we can only identify a contributing factor for RPL in about 50% of cases. This means we have a huge opportunity to learn much more about recurrent pregnancy loss and serve our patients. One future avenue for research, where we have a study undergoing right now at UCSF, is better understanding the genetic and molecular mechanisms that contribute to recurrent pregnancy loss. Zooming in further than the current clinical resolution of genetic testing to understand potential drivers from the genetic level of miscarriages is one avenue for important research. I think we need to generate better, more advanced therapeutic options for couples with RPL, which are limited at best at this moment in time. Clarifying the role of genetic testing of products of conception or POC specimens is important in finding and having an evidence basis to accelerate time to live birth for those couples suffering from RPL. I think we're only beginning to scratch the surface of understanding how things like sleep and exercise and stress may play a role in the couple's experience and outcomes. And I think we need better studies to differentiate and find modifiable factors to help our patients. And lastly, being able to better address at a personalized level what is contributing to repeated miscarriages such that we can tailor our treatments accordingly and best care for the patients is really, really crucial. I'd say that at the end of the day, one bright spot in all of this is that the prognosis for most couples with recurrent pregnancy loss tends to be very good, depending on age, with most couples ultimately having a child despite having suffered multiple miscarriages. And I am grateful to be able to participate in the care of patients with recurrent pregnancy loss. In summary, recurrent pregnancy loss, or RPL, is a multifactorial condition, and it requires a multidisciplinary approach. Comprehensive diagnostic testing is warranted in order to tailor treatment approaches for those 50% of couples in whom a cause is identified. And lastly, we need to direct resources toward better research for improving the care of couples with recurrent miscarriage. Thanks so much for your time today.